Good. Good evening, everybody. Thanks for joining. And hopefully we can learn a little bit more about prostate cancer. When you speak at events like this, you kind of never know where anybody is in their journey for prostate cancer. So I sort of tailor this to people who are sort of early on in the process. But I love questions. Don't hesitate to just throw them at me, and we'll get to as many as we can, and hopefully I can answer some questions. So I'm at Christ Hospital, an employed urologist there. Excuse me, I'm the chief of urology. I've been there for since summer of 2012. And prostate cancer is kind of a passion of mine, just from some family members who have gone through it, throughout my, life, and especially as I've gotten into my, professional career. So what I kind of wanted to talk about and really focus on tonight was some of the screening for prostate cancer, understanding the pathology of it, active surveillance, and then the surgical management of prostate cancer. So as the urologist, the surgical management is my area of focus. The radiation oncologists handle the radiation for it, and there's medical oncologists who handle, some more advanced, type medication options. So we'll just sort of stick with the local management tonight. So this is just a few basics of what we'll get into tonight. Some anatomy, some statistics, some signs and symptoms, screening, diagnosis, the grading system, and then the risk stratification and some treatment options. So some basics here. If you don't know, the prostate is a gland that's located just below the bladder. Us men urinate directly through it, and its function is in fertilization of an egg for reproduction, handle some of the enzymes and factors for that. In general, it's about a walnut size, but it can get significantly larger as us men age. Prostate cancer is the most common cancer diagnosed in American males, next to skin cancer. And it can exist in two stages. There's the early stages where it's contained within the walls of the prostate, which is treatable and curable. And then there is advanced stage where it spreads beyond the walls of the prostate to other areas such as lymph nodes and bone. Once it's at that stage, it's not necessarily curable, but it can be managed for a long, long period of time by slowing the growth and reducing the symptoms. So a few statistics here about prostate cancer. So about 1 in 8 men over the course of their lifetime are going to be diagnosed with prostate cancer. And it represents about 15% of all new cancer cases here in the United States. But it is the second leading cause of cancer death in U.S. males, second to lung cancer. What's interesting is if you look at the median age of diagnosis, the median age would be 67, but the median age of death would be 79. So what that tells us is that in general, this is not a cancer that will take our lives quickly. It's something that over the course of years tends to potentially, evolve and cause issues. And that's highlighted on these graphs here down at the bottom left of the screen. So that's looking at the 5-year survivals with prostate cancer. The far left is localized prostate cancer, so, within the walls. And regional means prostate cancer that would be not necessarily within the walls, maybe growing just outside the wall into some of the fatty tissue, but has not spread beyond the pelvis to, lymph nodes and bones and things. And you can see the 5-year relative survival is 100% in these men. Once it advances, to a more distant stage, that's where we really start to see a decrease in the 5-year survival, at 34%. So I bring this up. I want to highlight that because when we talk to a lot of patients, there's obviously a lot of anxiety about being diagnosed with any kind of cancer.
Mhm.
But I think that there is a definite sense that this is something that is immediately going to, harm us and end our lives. And, luckily that's just not the case with prostate cancer. It's more of we're looking more long term to prevent, harm to us guys. So what are the risk factors? So age is by far the biggest risk factor, more commonly diagnosed in men over the age of 65. Um, start to have that risk after we turn age 50. Family history is a significant risk factor, particularly if you've had what we call a first degree family member, such as a brother or a father, that's had prostate cancers. And as we learn more about just cancers in general, we're finding that certain other types of cancers are also associated with a prostate cancer. So ovarian, breast, particularly male breast cancers, colon cancers, some of the genetic things that we've all heard about, like the BRCA, these are genes, lead to higher risks for developing prostate cancer. And in general, black males are going to be more likely than white males to develop prostate cancer at an earlier stage and at a more progressed stage when we get diagnosed. We get a lot of questions in urology about, is it my diet? Is it my lifestyle that's, increased my risk of developing it, or will it increase my risk? And the fact is that there hasn't necessarily been any studies that have been able to validate anything, but looking at Western culture and prostate cancer rates compared to like Eastern culture, there does definitely seem to be something environmental related to our risk of developing prostate cancer. We just haven't been able to pinpoint that just yet. So what are the symptoms of prostate cancer? Well, frankly, early on, there really aren't any. Typically, it's detected by a abnormal blood test called a PSA, which we'll get to in a second. But most of the symptoms attributed to prostate cancer are the same things that an enlarged prostate would cause, which is, a weaker stream, going more frequently, having a sense of urgency, getting up at nighttime. As the cancer progresses, we can sometimes start to see blood in the urine, blood in the semen. It can grow into the nerves and blood vessels that cause erection, so it can start to cause difficulty with that. And when it really gets advanced, like as far as getting to the bones and things like that, it can cause pain at those sites. So commonly, it's the hips, the spine, the ribs, and the bone. And then weight loss is something that we can see with any advanced form of cancer. So for screening purposes, this is what the governing body of urology, the guidelines that are out there. So it's called the American Urological Association, or the AUA. So it definitely talks about shared decision making. So essentially a discussion between physicians and their patients about whether it makes sense to test for, prostate cancer and screen for it. The screening is with a test called a PSA, which stands for prostate specific antigen. So essentially it's a protein that circulates in our bloodstream. And the average man typically should start to be screened around age 45 to 50, and then should be routinely offered approximately annually to every 2 to 4 years, again, with that shared decision making. Age alone should not be a deciding factor. We get asked that question a lot. Just because you're a certain age doesn't mean we shouldn't or can't screen for it. It has to do with what we call your health age. And then there are other patients who are at an increased risk for developing prostate cancer. So that's like black males, those with known like mutations in their history, like the BRCA genes, or patients with strong family history. We want to consider maybe checking on those guys a little earlier, ages 40 to 45. So the PSA, as we talked about before, does increase with age. And so this is sort of a general range for what PSA should, quote unquote, ideally be by decade. So, if you look at somebody in their 40s, PSA 0 to 2 would be considered normal. In the 70s, up to 5 would be considered normal. So the normal, the upper limits of what we're checking definitely increase with age. But the PSA is not a perfect test by any stretch of the imagination. There's a lot of false positives. And there are men who certainly have, what are considered normal PSA levels for their age that do develop prostate cancer. And so that's why taking into account, more than just this test, the patient's symptoms, the family history, is just as important as what this one blood test shows. So it's confusing because not only cancer raises the level, things like infections, so infections of the urine, infections of the prostate itself, recent like ejaculation, like from sex or masturbation, can increase the levels. Exercise, particularly like bike riding, because of the pressure from the heart seat, can raise the levels. Catheters placed for other surgeries. So when you're evaluated for an abnormal PSA value, we need to be asking these questions and taking all these other things, into account. So when we diagnose somebody with prostate cancer, in general, like I said, it's an abnormal PSA that sort of starts the workup. And we always want to repeat the level because there are so many other factors that can influence where it is. But if we have a confirmatory test that shows, the PSA is still elevated, or there's those other signs and symptoms that increase your risk, we're moving more and more towards doing prostate MRIs as the sort of initial screening test. Previously, we used to go straight to biopsy, but we definitely we don't want to over biopsy people. We want to help sort of risk stratify who really needs to proceed on to biopsy and who doesn't. And the MRI is a very good tool for doing that. The MRIs, when the radiologist reads it, are going to give us a scoring system, which is called PI-RADS. And it's a scale of 1 to 5. And 3 would equate to about a 50% chance of prostate cancer, a 4 would be an 80% chance, and 5 is 90 to 100% risk. And these are specific lesions, spots, tumors, nodules. Any of those terms, can be used to identify a specific area on there that is of high risk. But again, the MRIs can only assign risk. It can't say yes, no, good, bad, or anything in between. So when we see these high-risk lesions, that's when we then move on to doing a biopsy. So the MRIs have also been able to increase our accuracy of biopsies because it can serve as a GPS to target these areas more directly. And the biopsies can be done either transrectally or transperineal. So essentially biopsying through the skin between the scrotum and the anus. I've transitioned pretty much exclusive to the transperineal because it's taken the risk of getting an infection such as sepsis, so the sickness where you end up in the hospital, down to 0% versus going the transrectal route.
Excuse me.
And then after we get a biopsy, if we do determine it's cancer, sometimes we'll talk to you about sending your tissue on for additional testing to help with the biology of the cancer. So a few of the tests would be Prolaris, Decipher, Oncotype, and I'll sort of hit on those here in a second. So if you get diagnosed with prostate cancer, you get assigned what's called a Gleason score. So the Gleason score is your pathology. So it's trying to determine how this cancer is going to behave based on how it looks under the microscope. The Gleason score is the traditional scoring system. You'll find a lot of research online about that. More recently, we've moved to what's called the grade grouping, just because it's a little bit easier to understand. But essentially, a Gleason score is a number from 6 to 10, with 6 being the least aggressive, 10 being the most aggressive. And then there's, in between, and we'll again get to all these. But essentially, the higher the score, the more poorly behaving the cells are going to be because they're behaving so poorly they can't even like organize themselves into, normal glands and things like that. So once you get diagnosed with prostate cancer and you get your Gleason score, we then assign you to a risk category. So the risk is of the cancer growing, outside the walls of the prostate and potentially metastasizing or spreading, to other parts of the body. So Gleason 6 would be considered low risk for those adverse things. Gleason 7 is intermediate, and you can be assigned a score of a 3+4 or a 4+3. 3+4 would be considered favorable, 4+3 unfavorable. And what that means is that the first number listed, so the 3 and the 3+4, means that the predominant or the most common cell type is of a lower grade than somebody who has 4+3, in which the predominant cell type is a more higher grade cell. So it's a little confusing. That's why we kind of have moved on to this next scoring system. But Gleason 8 to 10 would be considered high risk prostate cancer. And there are other things that lead to our, decision making and recommendations for patients, such as how many of the biopsy specimens are positive, whether the cancer's on, both sides of the prostate or just one, the PSA level, the family history. So more recently, we've transitioned to this grade group, which is a 1 to 5 scale, which is a little more, easier to sort of follow. 1 would equate to like a Gleason 6 or a low risk prostate cancer. 5 would be a high risk, a 9 to 10 on the Gleason score. And so a 3 equates to that 4+3 that we were talking about before. So 3, 4, and 4, 3 are different types of prostate cancer. This is kind of a busy slide, but it's from the NCCN, which is called the National Comprehensive Cancer Network. And this, again, breaks it down on the left side according to the risk groups, what the criteria are to fit into each of those groups. And then on the far right, where it says additional evaluation, that's their recommendations for when we need to do more testing besides just a biopsy. So imaging procedures like CT scans, bone scans, certain kinds of PET scans, things like that. We sort of touched on this before, but once we diagnose prostate cancer, we'll often talk to you about whether it makes sense to send off some of these genomic tests. And they're not genomic tests like sequencing your genome or anything like that. It's looking at genes within the cancer cells that we've already biopsied that are prone to cellular growth and division. So the Gleason score, the grade group, is what does it look like under the microscope? And, we feel like that will correlate to behavior, but sometimes things look differently to different people. And so these tests are geared looking more at how we think it's going to behave at the biologic level, the genetic level. So the 3 most common ones that we use are Prolaris and Decipher. These are just the number of genes that each one looks at. And then Oncotype is one that can be used to help determine whether you're a good candidate for, active surveillance or treatment. And some of the endpoints that these tests provide us are the risks of, like the percentage risks that the cancer could kill you at 10 years. So that's called prostate cancer specific survival. And then the risk of metastasis or risk of cancer spread at the 5 and 10-year mark. So these things really help, allow us to prognosticate a little bit better and help guide treatment decisions. So one of the options that's, is going to be available is called active surveillance. And active surveillance is not, no treatment. It is a form of treatment. We're just not doing what we call definitive treatment with like surgery or radiation. We're monitoring the cancer very closely to make sure that there is no signs of progression. The benefit of active surveillance is that we're not subjecting the patient to the potential for adverse side effects of the treatments. Um, no matter how good our surgeries have gotten, no matter how good and focal our radiation has come, there are still side effects to any form of treatment. And so why subject somebody to them for a cancer that potentially won't, hurt them? And so that's what active surveillance is and why why we're looking at it. So who are candidates? Because certainly not every man is a good candidate for active surveillance. The ideal candidate is somebody who's in what we call the low risk category or the very low risk category. So essentially, those are patients who have Gleason 6 or grade group 1 cancer or less. The very low risk patients have very few cores positive on their biopsies. And we're looking ideally for patients with PSAs 10 or less. Some patients will go up to 20 or less. And then recently, over the last several years, we've started looking more at can patients in that favorable intermediate risk category, so patients with like a Gleason 3+4, are they potentially candidates for active surveillance? And in this case in particular is really when those genomic tests can be extremely helpful. Patients with higher risk disease are typically not considered favorable for active surveillance, just because we sort of know that these cancers are going to behave poorly without getting treated. So again, these are the highlighted here as sort of the ideal candidates for active surveillance, along with the criteria that we're looking at to sort of help fit you, into these categories. What are the protocols? Well, there's a lot of protocols that are out there for how you do active surveillance. The one I have sort of typed out here is from the NCCN, but there are also the AUA has its own protocol. The Radiation Oncology Society has its own. The European Radiation Society has its own. So there's a lot of variations on this, but the common theme between all of them is PSA testing, approximately every 6 months. A lot of people will do, every 4 months. A digital rectal exam, once a year. A repeat biopsy is definitely something that is incorporated as part of the monitoring. A lot of centers really like to perform a repeat biopsy at the 1 year mark. And what we're looking to see is that the pathology hasn't, one, increased in volume, two, hasn't increased in, aggressiveness level or pathology score. And then from there, the biopsies, sort of get tailored to the patient's health, the patient's wishes, patient's life expectancy, what the PSAs, what the prior biopsies and things have done. So, I definitely don't want you guys to think that, going on surveillance means every year for the rest of your life you're getting a biopsy. That's definitely not what we're trying to do. But if things change, the biopsy is really what tells us the most, information about the biology of your cancer. And MRIs also, absolutely play a role, in this monitoring. So when do we make this decision to transition to treatment? It comes down to patient choice or anxiety. Being diagnosed with cancer is tough, and it weighs on guys. And we have MRIs and biopsies, and we have all this objective scientific data we can look at. But what we can't classify is what's the stress level it causes on the individual patient. And if it's something where it's keeping you up at night and you're worried and, despite our reassurances, it is really affecting your quality of life, then sometimes we just need to treat you and just get rid of the cancer and move on with life. Obviously that's a patient, by patient decision. Some of the more, objective things that we look at would be what we call grade reclassification. So essentially, the pathology moving up the, aggressiveness scale, moving up the Gleason scale. And then if we're seeing significant changes in the volume of cancer, such as if it, started on just one side, now it's on both sides. Maybe it started in just the back of the prostate, now it's in the front, in the middle. There's a lot of things we look at, but the grade reclassification and increased tumor volume are the two biggies we're looking for. There was a big study that was done and published in JAMA looking at the 10-year outcomes after with active surveillance compared to surgery and radiation for localized prostate cancer patients. And so these guys got split up into 3 different categories: the active surveillance, surgery, radiation therapy, and they each had about, approximately 550 patients, so a very large study. 8 men in the active surveillance category eventually died from their cancer. 5 in the surgery category died from their cancer, and 4 in the radiation therapy died from their cancer. So if you look at where it says at 10 years, though, so essentially 10 years from when this study began, 98.8% of men in the active surveillance category were still alive from their prostate cancer, compared to surgery, which is 99.0%, and radiation, which is 99.6%. So, essentially 98.8% to 99% is a 0.2 difference, which is not a statistically or clinically significant change. And so this was really the landmark study that we looked at and said, hey, in the appropriately selected patient, this is a very viable and safe, option for men. Throughout that study, as they monitor these guys as time went by, at the bottom you see the years of follow-up going from 0 to 10. On the left side is the percentage of patients who ended up getting treatment. And so at 10 years, about 50% of men ended up eventually moving on to treatment, even though only 80% had no sign of their cancer getting worse. So to repeat that, 80% of these guys, their cancer did not get worse, but overall 50% ended up getting treated. So what that tells us is that there are things other than the objective data, the biopsy changes, the PSAs, that influence our decisions, patient preference, anxiety, etc. So what my specialty is the surgical treatment for prostate cancer, which is called a radical prostatectomy. And what radical means is removing the prostate along with the attached, what we call seminal vesicles. So those little glands which are tucked underneath the prostate and up under the bladder are what store and hold the semen of men. And the surgery, the radical prostatectomy, can be performed in what we call nerve sparing or non-nerve sparing, which relates to sexual function. After the prostate has been removed, we have to suture the opening of the bladder back to the tube that we urinate through inside the penis, called the urethra. And then we also may sometimes remove or sample lymph nodes that are in the area to check for spread of the cancer. So the goal of prostate cancer surgery is for curative intent. It's indicated for men with localized cancer who are expected to live 10 or more years. And again, age alone is not a determining factor. There is a lot of discussion online, a lot of discussion in the community that after a certain age, you're not suitable for surgery. And frankly, that's just not too true. Again, it depends on your health age. The surgery, it can be performed via open, which means like a larger incision on the abdomen, or what we call minimally invasively, so small incisions on the abdomen. And that's really become the gold standard, which is the robotic assisted surgery. It it requires typically an overnight stay in the hospital, although we are slowly transitioning to, being able to get out of there the same day. You do have to have a catheter in place for 7 to 10 days, again, depending on the surgeon and the specific circumstances. And that's to allow that suture line where we reconnected the bladder to heal properly, so it heals in a watertight fashion and there's no urine leaks that occur. And then we follow the cancer afterwards with PSA checks. We would expect the PSA to go down to 0 post-surgery, and typically we start checking that at about 6 weeks after the operation. After the prostate's removed, it goes to pathology, and they then go through the entire prostate to be able to tell us the final, what we call stage of the cancer. So essentially, was it completely organ confined? Was there any growth immediately outside the walls? Was there any growth into those seminal vesicles? Because those are the things that help determine the potential risk of recurrence and the potential need for additional treatments like salvage radiation or hormones, things like that. So this is a little bit older version, but this is essentially what the Da Vinci robotic surgical system looks like. So the patient would lay on that blue bed, under general anesthesia. The robot has these instruments attached to it that go through small incisions in the abdomen. And then the surgeon is in the same room right next to the patient, looking through what we call a console. So one of the incisions in the patient is the camera that the surgeon's looking through, and it highlights the anatomy up to 10 times our magnified normal vision in a 3D high definition view. And then we have assistants at our bedside to help pass in stitches. There's the whole anesthesia team. There's the nurse. So there's a whole team that we routinely work with. That way, there's good communication, and everybody knows the process start to finish. The advantages of doing this robotically versus the older method of what we call the open surgery is significant in the reduction in pain and reduction in the narcotic use. Most patients go home from the surgery taking Tylenol and ibuprofen primarily for their pain, along with ice packs. Pain meds, have their narcotic pain meds have a lot of, negative consequences, particularly as it relates to bowel function. It can cause pretty severe constipation, which is something that sometimes bounces patients back into the hospital through the emergency room. It can, lead to, pneumonia, a lot of reasons to try and avoid those things. Significantly reduced the hospital stay from previously it was multiple days up to a week. Now it's just overnight or sometimes an outpatient surgery. Significant reduction in the amount of bleeding that occurs during surgery. Typically, we're just looking at very minimal, not anything near where we consider doing blood transfusions. Much quicker return to work. And there is an improved control of the urine leakage and sexual function because of the magnification and the fine movements that the robotic system gives us. So the picture on the left is sort of generally how the incisions would go. So the white one in the center there is right around the belly button. That's usually where our camera goes. The 3 that are like silver metallic with the green tips are where the robotic instruments go through. And then the one on the far left is where the assistant would be able to pass in stitches and things like that. Inside the body, this is what it would look like after the prostate has been removed. So at the 6 o'clock position down there is where the opening of the bladder was, because the prostate sat adjacent to that. The urethra, so the tube that goes through the penis to urinate through, is at the 12 o'clock position. And so that is where we make that reconnection to reestablish the normal flow of urine. But there are side effects, unfortunately, of prostate cancer surgery. And any man who goes through this, no matter how young, how old, is going to have these initially to some degree. Luckily, they will get better. The first one is called stress incontinence. So that's leaking urine from coughing, laughing, sneezing, bending over, twisting weird ways. Anything that increases your abdominal pressure pushes on the bladder, and the muscles initially are too weak to be able to hold that back, and so some leakage occurs. Initially, it does require the use of adult diapers, but as you get control back, you get rid of those diapers, transition to some pads and liners, and then gradually decrease how many you need of those, and ultimately we'll get rid of them completely. So the average guy will take somewhere between 6 months to a year to get that urine control back. And about 5% will have significant leakage beyond a year. So 95% typically don't. It's very important that the patient, be an active participant in their own recovery by doing these things called Kegel exercises, so pelvic floor strengthening exercises. The program we have at Christ Hospital, we have you meet or encourage you to meet with a pelvic floor therapist pre-surgery just to get some pre-strengthening and muscle memory built up. And then we also want you to do that post-op just to get you back on track. And this significantly enhances, or, speeds up the recovery. Of the men who just, for whatever reason, never fully get their control back, there are surgical options that are out there to be able to, get things dried up for you. The other side effect that we always talk about is the erectile dysfunction and the recovery of that after the surgery. So inside the body, the nerves and blood vessels for sexual function are draped right on the outside of the prostate. And so when we're doing what's called a nerve sparing surgery, we're able to get into that junction between the prostate and this group of nerve and blood vessels and sort of gently tease them off the surface and just put little clips on these little blood vessels that feed the prostate as we go by. So we're able to preserve the plumbing, but it's that manipulation that does cause the dysfunction for a while. Men with a more aggressive cancer or a cancer that, potentially on the MRI, we're maybe seeing grow into those nerve bundles, we sometimes have to remove them. So that's what's called a non-nerve sparing surgery. The biggest factor in what determines whether a man regains a sexual function or not is actually their function going into surgery. So those with, significant erectile dysfunction going into surgery certainly aren't going to get any better, by removing the prostate. Age and your other health issues also play a major role. Less than 60 by far has the best chances for recovery. And then the general health conditions that affect blood vessels, such as diabetes, high blood pressure, heart disease, anything that causes plaque buildup in blood vessels is something that can prevent the recovery of sexual function, post-surgery. So there's a lot of studies, and we have a protocol that we've set up where we start you taking medications like Cialis, sort of immediately post-op once that catheter comes out, to just start improving blood flow and oxygenation to the penis to help restore, function and prevent scar tissue buildup. We also recommend relatively early in the recovery process, patients purchasing this thing called a VED, or vacuum erection device. So essentially an external cylinder that goes over the penis, and the vacuum sort of mechanically helps pull the blood down into the penis. And the combination of doing that 3 times a week, plus the medications, will help to speed up and recover sexual function. But it can take a little bit longer than what the urine control does. Your return to sexual function can take sometimes up to 2.5 years for full recovery. And so, it's very important to have, be upfront about these expectations pre-surgery. And in particular, speaking to partners, that, this is going to be a, process, and patience and support, goes a long way. After surgery, we allow patients to return to work anywhere from 2 to 6 weeks post-surgery, depending on the job. It is 6 weeks of lifting restrictions, and that's just for prevention of hernias. And then at the 6 week mark, like I said before, is when we start checking your PSA. We expect it to be 0 and hopefully always 0 from there. And then we do it in general every 3 months for year one, then transition to every 6 months, and then potentially annually, after that. So if the number should rise, this is when the PSA is actually very sensitive or very accurate, because at this point with no prostate in there, it's able to tell very minor changes in prostate cell activity. So we can detect recurrences very, very early post-surgery and then initiate the workup from there.